most common heart disease in pediatrics. Sorry. And as you can see here from the conclusion, like male tend to have more complex congenital heart diseases with more obstruction of the left outflow. Is that females tend to have less complex. So speaking about the real diseases, so women tend to have more atrial septal defect and PDAs, so very, very simple. Sometimes VSD, so ventricular septal defects, there are minor lesions. Instead, males tend to have more complex, like transposition of the great arteries, tetralogy of Fallot, apoplastic left heart syndrome. Said so, how they do, I mean, I put this article because I think it gives really an explanation why we can see, this kind of important difference between the prevalence of diseases is a genetic study. So basically here on 800 kids with congenital heart diseases, that study a lot of very rare genes. And they've seen that the variance between the males and females were different. And probably what they were concluded that is that probably all the variants that are in the female patients that are more than the males ones tend to have a biological protection towards the development of congenital heart diseases. On top of these, so we said different conditions, but there is also a different adaptation to the cyanosis. So the very complex congenital heart disease are called cyanotic because not much of the oxygen arrived to the body because the heart is not functioning properly. Sorry, I said it very step by step. And you can see here in this article that it's quite evident that the metabolic activation is much better in female compared to male. So it seems that hormones or all the factors that I told you before helps the females, so the female patients, to activate this metabolic pathway that are more protective to adapt to the cyanotic effect of the condition. But on the other side, this other study shows us that in patients that are undergoing a surgery, actually are the females that have much more rate of death after cardiac surgery. Another important thing, for who does congenital heart diseases, so the cure for the most of those conditions is surgery. And as we know, like during important surgeries, there is always a time of bypass, so a time where the brain does not get enough oxygen. And this has always been associated with delayed neurodevelopment, but also the hypoxic status is something really connected with the congenital heart diseases in general, because as I said before, the complex one are called cyanotic. So these are very nice studies that showed and follow the patient and the time, and go and see basically the neurodevelopment and the motor development between female and males. And once again, seems male having more neurodevelopment defects or delay compared to the female. And this seems connected to what I was saying before. So for the factors I mentioned at the beginning, probably the metabolic activation in women is more protective to the cyanosis. And that's why male children tend to have, more poor outcome. Then I'm coming to another spectrum of diseases, less representative with respect to the congenital heart disease, but is my passion, so cardiomyopathies, because it really links adult and pediatrics at the moment in the center where I am, in particular at Gosh with Professor Kasky. And this article that gave me hope that I could go back and do gender differences also in what I was studying at the moment. So it's been published by my secondary supervisors, Gaby Captur, as a multi-center study, and it really studies the symptoms, but also the outcomes of pediatric patients with hypertrophic cardiomyopathy. Is a very big number for kids, so 1,400 patients, and quite, understandably, until 12 years of age, there are no major differences, and we can think about probably the hormones kick in. There are other articles for inherited cardiac condition that shows how much adolescence is a very important phase where they should be reassessed more often in terms of cardiac risk. And what is striking here is that females tend to be more symptomatic and to have more heart failure symptoms compared to male. But in terms of outcomes, so death in particular, there is no difference. And these are, I think, probably Gaby will say something, equalize what has been seen in the adults. Same here, this is a paper for dilated cardiomyopathies. Is actually more focused on adults than into pediatrics, but it's starting to say something about pediatric population. Obviously mentioning that needs more studies, but once again, like in the adult world, the dilated cardiomyopathy seems more frequent in male compared to female, but the differences that are here represented in the figure are not very much enhanced in the peds population, probably because there are not much studies. Then finally, again, in another branch of the inherited cardiac conditions, there are the inherited condition of the rhythms. We can find the sex differences also in the pediatric age. There is a table here that shows like hormones are affecting the QT. There is a segment on the electrocardiogram that is connected with arrhythmias, with malignant arrhythmias that can cause death. And long QTs are genetic syndromes that are associated with arrhythmias and then sudden cardiac death. And you can see the estrogens can increase the long QT, the QT interval, as you can see in the table. Progesterone decreases and testosterone decreases. Why all this? Because actually, between all the diseases that are treated in that in this paper, long QT is the one that just show a difference already in peds in terms of sex. So males tend to have more arrhythmic events, so ventricular arrhythmias that can cause death before puberty. And then after puberty, females start to equalize the numbers of events. This is again a slide to summarize all the factors that can come in and affect the differences between the two sexes. Another point that I want really to touch, maybe to leave it down the word to Gaby in a way to the other word, is this thing that we call transition, that is not just a transfer of our kids that are affected to the adults. It's a really long process that starts gradually to make them understand what is going on and to prepare them to the adulthood. Because what we always say to our kids is that we're really lovely, we're gonna chase you, we're gonna call you, we're gonna stay behind you, but then when you go to the adults, you have to know that if you don't show you up for 2 times at your appointment, you're going to be discharged. And that's not very good because you have a condition and you need to be followed up. So this is an example to make you understand that it's a long process also done with the nurses to make them aware of what they have and what they have to look after. And it's both equal for the two sexes. But what is being nicely shown in this paper is that actually male in that period tends to have a less adherence to follow up. I don't know if Gaby is gonna talk about this later, but what was said when I was another cardiologist that there was a lot of other way around problem in adulthood because female, in particular, like in third world country, do not attend appointments for cardiovascular health because they have to take care of the houses. And so it was also an explanation given in many trials to say why the reason why they were not actually participating to the trial or test of new medications, but I don't know if things changed. And then why I focus also on transition, because for a female part, there is a lot of things that needs to be mentioned that are not going to be mentioned to males. So the menstruation coming in, the pregnancy, and then obviously in the older age, we have all the stage of the menopause. So women are going to have a cardiovascular condition that needs also to deal with this gynecological aspect. And it's very nice that also new cardiologists are actually developing knowledge on this topic. That sometimes is really kind of a question mark for me when like someone comes and say, I need to start a pill, but I don't know what to start. And you look at the literature and you just have one line of indication and like on a guidelines, and there is no much. So thankfully, this is enlarging. Sorry, this was just to show you where actually the things that needs to be added to the transition of the female. And then I arrive at the very end. So I hope that I show you through, particularly the last slide on the condition, that there is actually the first proofs of sex differences, and that should be better studied and understood in order, to better follow up the patient, and in particular to better stratify the risk. And in my opinion, coming also for the adult words, to better understand the symptoms, because I remember, like, I was misled so much about specific symptoms in women compared to men, because when I started cardiology, what I was told is that the myocardial infarction was just chest pain with pain in arm. And then you see like women that are not identified with the infarction because they had like very specific symptoms. And this is true also for, I believe, in a part for kids, and particularly in the article that I show you about hypertrophic cardiomyopathy, like they're coming and they have heart failure symptoms. This means shortness of breath, tiredness. Instead, the males have more obstruction of the left outflow, so they come again have chest pain and so. But that's everything for me, and I really want to thank you. I want to thank UCL and also my equity team from UCL, because they helped me to spread in university this event, this first edition of the event will be done in Istanbul this weekend for the Day of the Women Vitals in Cardiology. It's been a very nice event where we'll talk about sex differences in pediatrics, in adults. We were more focused on adults, honestly, because more literature is on that topic. But we've done also a lot of mentoring and sessional leadership and how to overcome difficulty in your workplace. And we came out with the ABCD code for supporting women in cardiology that I think be actually kind of used in each branch of medicine and not only. So, hey, acknowledge and amplify. What does it mean? If you're in a meeting and you see a colleague female that is always interrupted with no reason and is not given the possibility to talk, just please acknowledge it and say, please, can we leave the space to Julie to speak, whatever. Back opportunities, like in particularly the women that are in a higher position, think about giving possibility to other women. And create first systems, like in the departments, try to be clear about the criteria on which research studies or procedures are given to someone instead to another, instead that people that wants to do something can actually follow the right step to arrive there. Because sometimes, I think this is particularly true for more interventional branch of medicine. Sometimes there are no rules, like the strongest goes to the operative room. Instead, should be more fairness and more transparency about how this should be organized and should be respected. Disruptive bias is a bit the last pillar, like instead about not discriminate for all the period about pregnancy and caregiving that women have. Thank you very much. That's it. Thank you.
I, for one, didn't realise it was so many videos on different things.
Yeah, it's very striking. Yeah.
Yes, please. That looks good. Excellent. Thank you so much. I hope you can all hear me. My name is Gaby Captur. I'm a cardiology consultant at the Royal Free and an academic at UCL with much of my research focusing on cardiac MRI imaging and cardiomyopathies. It's a real pleasure to be here. So thank you very much for organizing and for inviting me to talk. Today, I'd like to talk to you about a really important problem that's hiding in plain sight, and that's the fact that women are not small men. And yet we continue to diagnose them and treat them as if they were. And during my talk, I am going to be focusing predominantly on three important aspects. The first being the primary prevention of atherosclerotic cardiovascular disease in women. The second being the use of gender agnostic imaging thresholds and how they are continuing to put more women at risk. And thirdly, and most importantly, perhaps, the complexity and the misunderstanding around chest pain symptoms in women. So starting with this concept of clinical trials for primary prevention. So for decades, women have been underrepresented in clinical trials, in some of the major clinical trials, including statin trials like WASCOP or the 4S trials. These trials have persistently underrepresented women, underanalyzed, or quite simply excluded them from clinical trials. And if you do take those landmark statin trials and you look at the data, most of them were actually based on male populations predominantly, with women only comprising about 15 to 30%. And this really matters because when evidence is derived predominantly from males, then unfortunately clinicians are going to be less confident applying that evidence to women. That promotes physician hesitancy. And physician hesitancy comes at a great cost for the woman because it translates into a really important care gap. Okay, and that means that statins are underprescribed, that guideline-directed medical therapy is less commonly used in women, and if the woman does experience a major cardiovascular event, she is less likely to receive appropriate treatment, or as that treatment is delayed. So there is a major problem here in terms of how these primary prevention studies are being carried out, and beware of the fact that even nowadays, with all our knowledge around the importance of inclusion and gender equality, in spite of that, presently in the major cardiovascular clinical trials, women only comprise 1/3 of those cohorts. So it is still a very pervasive problem. And this problem is further exacerbated by the fact that most of the most popular and ubiquitous cardiac risk stratification tools that your GP would use or your cardiologist would use if you go to them and see them for the first time, and they use it to try to estimate your risk of having a major cardiac event within the next 10 years, those risk stratification tools are based on cohorts that were mostly comprised of men, unfortunately, and that includes the Framingham Heart Study. And what that means is that cardiovascular disease risk in women is going to be systematically underestimated. And this is quite serious. It means that women are going to be put at a disadvantage, they are less likely to be offered statins, and there's going to be less evidence. It really murks the waters for clinicians, and it is a very major problem. But we're not doing very much better in the imaging domain either, because if we take a look at echocardiography, for example, and we look at how imaging is performing, how well are we imaging the hearts of our women, there is definitely progress being made, but there are still major issues. Take echocardiography, for example. We know that the hearts of women are structurally smaller, and yet we still, till this very day, index the most basic of parameters like left ventricular mass to body size. And we use thresholds that had been established from mixed populations. What that means is that a woman who would have genuinely hypertrophied and pathologically hypertrophied ventricles would go missed. And the diagnosis is never applied, and no treatment is undertaken, family screening is not cascaded. And also, equally, with echocardiography, there is the issue that in younger women, they tend to have higher filling pressures and higher E to E prime ratios at baseline. And what that means is that echocardiographers are more likely to misdiagnose the presence of diastolic dysfunction, particularly in these young women, if sex is not taken into account. The grass is no greener for invasive epicardial coronary angiography, which you would have thought is the ground truth. Well, there are major issues here as well. Why? Because coronary disease in women is quite different to the coronary disease we see in men. So in women, coronary disease is more likely to be consisting of microvascular dysfunction. They are more likely to have diffuse disease or non-obstructive disease, but disease nonetheless. And unfortunately, these women who will have convincing and genuine angina symptoms go on to have an invasive coronary angiogram, but the epicardial coronaries are found to be intact and they are labeled as being normal. So stop complaining, you don't have angina, actually, you can be discharged from my clinic. That tends to be the approach. But of course, a lot of research is now showing that while invasive coronary angiography is excellent at identifying focal stenotic coronary artery disease, it is really much less effective and sensitive at identifying those other patterns of disease which tend to afflict the female population. And that is, of course, an important problem. And it really does matter because we know that in a large number of cases, women, because of these reasons, are about 20 to 25% less likely, even if they've had a major cardiac event, to receive guideline-directed therapy when compared to men, simply because of these mislabeled diagnoses. And equally, there is a similar problem that also limits the use of CT coronary angiography. Again, women tend to have more non-calcified plaque and diffuse disease. And what that means is that if you undertake a CT coronary angiogram, which is essentially intended to reflect the burden of calcified plaque in the heart and the coronaries, there is a large number of women are likely going to have very low calcium scores, which are going to be falsely reassuring, but they are still going to be at significantly high risk. They would still have critical stenoses that's simply not captured because it's non-calcified disease. And this therefore underscores the reason why interpreting coronary calcium scores in women in isolation without the rest of the angiographic data is potentially dangerous, because it could result in false reassurance when actually there is significant disease and these patients are at risk. If we were to look at nuclear medicine, still fraught with problems. And the reason for that being that SPECT, for example, is limited by serious attenuation artifacts that only happen in women because of their breast tissue and because they have smaller hearts. So nothing that the woman is to blame for, but unfortunately what that means is that a woman who's having a SPECT imaging scan because she was suffering from chest pain and the doctor was suspecting angina is very likely to have artifacts identified. And these artifacts can result either in a false positive diagnosis, or if that artifact was genuine and there was really underlying ischemia, the reporter might just say, oh no, that's just breast artifact, she's got large breasts, let's ignore it. But actually there could have been genuine ischemia in that territory, which again goes missed. So it creates a lot of diagnostic uncertainty. Of course, nowadays there are lots of advances happening in medicine with attenuation correction and the advancement in PET, but these advanced processes and modalities remain quite inaccessible across most centers. And then if we were to focus on the Rolls-Royce of cardiac imaging, which is cardiac MRI, which I tend to do a lot, it's not perfect either, and also struggles with important sex biases. And in particular, for cardiac MRI, I always like to refer to the concept of hypertrophic cardiomyopathy, which Sara has already described. It is this sometimes genetic condition where the heart thickens unnecessarily in a pathological way. And historically, hypertrophic cardiomyopathy has always been diagnosed based on this raw cutoff. Is your heart thicker than 15 millimeters or is it not? It's a very crude metric. And of course, it was developed over 20 years ago without any consideration at all for the sex of the individual. And unsurprisingly now that we're looking at this with a better periscope and with better imaging, there's a lot of data coming particularly from UCL groups to say that actually this 15 millimeter cutoff is not good for purpose, and it was derived from cohorts of predominantly men without any gender consideration, and it's actually missing a lot of women who have pathological hypertrophy. So nowadays there is a move towards newer methods, better methods that incorporate sex, body size, and AI-based methodologies and deep phenotyping in order to rectify this sort of injustice, shall we say, so that women who have thick hearts and who therefore are at risk of sudden death don't get missed. And then moving on to the third aspect of my talk, which is focusing on what really matters, this concept of chest pain. So I think we started this session by reminding ourselves that cardiovascular disease is still the main killer of women across the world. In spite of that, you'd be surprised to know that women are much less likely to be referred for investigation, much less likely to have a proper diagnosis applied to them. And even when a disease is diagnosed, they're more likely to face delayed treatment or no treatment at all. And this is a great shame in terms of cardiovascular medicine and what we are providing to the female population amongst us. And one of the reasons for this really is a perception bias, because women tend to present differently when they experience major adverse cardiovascular events, in particular like heart attacks. If a man experiences a heart attack, they are most likely to describe severe crushing chest pain with nausea, perhaps radiating into the jaw and then radiating into the arm. This will resonate with any healthcare professional because we've been indoctrinating them about these symptoms in medical school. It resonates with what's in the media, what people expect. And therefore, the man who's experiencing the symptoms is more likely to believe himself and believe that he's having a cardiac event. And also, bystanders are more likely to encourage him to seek expert urgent medical help, as rightly would be the case. But move on to the situation of women. Unfortunately, women will present very differently. A myocardial infarct in a woman is more likely to present with fatigue, breathlessness, epigastric pain, palpitations, perhaps presyncope, loss of consciousness, or dizziness. So these are not atypical symptoms. These are typical symptoms of a myocardial infarct in a woman. And that difference really matters. And this is where the presentation bias can really impact how well women are treated for their major cardiovascular events when they occur. Women, unfortunately, because there's not enough education about this, are more likely, therefore, to ascribe their symptoms to anxiety or indigestion. And unfortunately, their family and friends, the bystanders at work, are more likely to sort of not really care and let it go, as opposed to a man with other contrasting symptoms. So there is this different symptomatic presentation. But then, even assuming that the woman is brave enough and plucks up the courage to go to A&E, having sorted out the kids, the mother, the work, the food and everything else, so that she's managed to get to A&E, believe it or not, there's still more than a 50% chance she is going to receive the wrong initial diagnosis when compared to men. And the reason for that is because, unfortunately, heart attack mimics are so much commoner in women than they are in men. And there are a lot of them. INOCA, MINOCA, Takotsubo, and SCAD. Those are the ones I'm going to be talking about now. What is INOCA? You've probably never even heard of it. And you're women. I see most of us are women in this room. We are speaking to the converted. It really is important that you know about these conditions, actually, because INOCA is going to affect women almost 70% of the time. They are very rare. They're much rarer in men. So this is myocardial ischemia with no obstructive coronary artery disease. So these women are reporting angina, very convincing cardiac symptoms. They have an angiogram, but they're found to have completely normal coronary arteries. So there's no gross epicardial coronary artery disease. But underlying this, there is still disease and pathology in these hearts. There's usually microvascular dysfunction or endothelial dysfunction that is causing genuine ischemia and therefore triggering genuine symptoms. But unfortunately, these women who have been given this label of a normal coronary angiogram are usually discharged by their GP. The efforts in terms of continuing statins, perhaps the incentive is lost, and all the pressure on maintaining secondary prevention, lifestyle changes, etc., also starts to dwindle. And suddenly they are more at risk than they were before they even presented to A&E. And this is wrong, because we know now that INOCA is not benign. INOCA is associated with more hospital admissions, with poorer quality of life, and with more MACE outcomes. So it's really important that women who have this diagnosis are counseled by GPs, they're not discharged, that all the attention is given to them for secondary prevention, as we do for men who have sustained a standard classical myocardial infarct. And then we've got this other one, MINOCA, myocardial infarction with no obstructive coronary artery disease. So here we have women who have a proper myocardial infarct in terms of ECG changes, enzyme levels. There is injury. We can see injury of the heart muscle wall, be it by echocardiogram, where we can see that there's some paralysis, or be it by cardiac MRI, where we can see visible scar. And yet they have an angiogram and it looks normal. Aha, we're all happy and reassured. But no, there has been a myocardial event. It's just that it happened in a different and unusual way. Perhaps there was a thrombus which spontaneously dissolved. Perhaps there was a flush occlusion of a vessel without any residual stump, and it's completely invisible to the angiogram. Perhaps this was a tiny little blood clot, and we call it paradoxical embolism, which led to the occlusion. So these women who suffer mynoca have had a cardiac event, and it is just as important and just as prognostic as the standard myocardial infarct that happens in men. But again, mynoca predominantly, largely a disease of women, much, much less common than in men. And then we have Takotsubo cardiomyopathy. This is slightly more popular, attracts a lot more media attention. We also call it the broken heart syndrome or the stress-induced cardiomyopathy. Here, this tends to affect 90% of cases. It's women, and it's going to be post-menopausal women, and typically after a major emotional or physical event, which results in a massive surge and release of stress hormones into the bloodstream. What happens to the heart? The heart, unfortunately, goes into this state of paralysis, and the apex will balloon and will not work properly. Takotsubo cardiomyopathy is not benign. It can happen very unexpectedly and suddenly. It constitutes an acute coronary syndrome in itself, in a sense, because of how aggressively it presents. And sometimes women who present with Takotsubo cardiomyopathy are critically unwell. Sometimes they might need to have an emergency ICU admission. They might need inotropes. And myocardial recovery is not guaranteed. Of course, this is an important mimic. Okay, so this is not a myocardial infarct. When these women have their angiogram, the angiogram is normal. But still, there is severe and important myocardial disease taking place, which could affect their outcomes. And then I wanted to close with the last example, which is SCAD, spontaneous coronary artery dissection. This is probably the most feared of all. Again, prevalent in women, usually young women. In 70 to 90% of cases, it's going to be young women who experience SCAD. It's devastating and it's life-changing. What happens is that in an otherwise unobstructive coronary arterial tree, unfortunately, there is an unexpected tear inside one of the main coronary arterial walls. And where the tear happens, because it's so acute, platelets aggregate and a thrombus forms, and you definitely get occlusion of that artery with resultant myocardial infarction in that territory. So they present like a classic myocardial infarct, but it is a mimic. They go on to have an angiogram, and thankfully, before the wire is advanced, the operator realizes there's a tear and everything stops. You pull away very gently because you don't want to make it worse. Okay, and this is the reality of SCAD. So these patients are very often young, and there are multiple cases. It's a very mysterious disease. It's shrouded in mystery. We don't yet know all the precipitating factors. There's a lot of research going into SCAD because of the impact it's having on young women's lives, albeit rare. It is really quite devastating. Okay, and we know about some associations, some risks, like pregnancy, certain hormones can predispose, as also fibromuscular dysplasia, but there's so much we don't know about SCAD. So there's a lot of research at the moment and interest by the BHF, thank God, and lots of other funders to try and really unravel this very important condition. And yes, when it happens, it's really dramatic and very acute. There are lots of case reports in the literature about young women experiencing SCAD when sitting at the cinema watching a movie, standing in the kitchen and cooking, when pushing the pram in the road. These are really dramatic, acute presentations. So I think, to summarize it all, I think that the focus of my talk really is to help us understand that although modern cardiovascular medicine has made some really impressive progress over the decades, I think, unfortunately, it is still lumped with this legacy of inequalities when it comes to the care, the diagnosis, and the treatment of women. I think it is down to us to address this. It's important to realize that these inequalities exist. They are flexible, and we can potentially change them. The way to change them really is to listen to our patients, to train our healthcare force so that they can recognize these signs when they see them, to focus on precision imaging, improved risk stratification, and proper inclusion in science and research. I want to assure everyone who's here and online that as researchers, we are aware of the problem. We are everybody around the world, not just at UCL. We are working with patients, clinicians, and funders to address this, okay, and put an end to this injustice. And I believe that we will get there through better science, better data, and better care. Thank you all for your kind attention.
Thank you so much. I've got a lot of questions, but has anyone else got some questions before I start the ball rolling? Yeah.
Hi. So you mentioned that when you go and see when you're having these scans done, that there's a discrepancy with measurements. If a patient was going in that situation, how could they advocate for themselves now that I know and say, I think these measurements might be inaccurate? Can you kind of push back on that and say, I think these measurements might be inaccurate. Can you kind of do it again or figure out how it might kind of be in line with me being a woman?
So I think that's a very valid question. I think a lot of centers nowadays are trying to incorporate these more sophisticated kind of sex stratified cutoffs and diagnostic thresholds, but it is not widespread. So it is very likely that if you go to an NHS trust, you might encounter this problem. It only really becomes a problem if there is an issue about things like wall thickness, mass, etc. Usually, a lot of the metrics and the measurements that we see in our reports do have some limited amount of stratification. As I said, it's to body size. But again, it's usually to body size that's at a population level. So if you are at one of the extremes, you are more likely, unfortunately, to be unrepresented in that estimate. To answer your question, I think it is always good to have a conversation with your cardiologist who's interpreting the data. I think it's probably less helpful to speak about your concerns to the echocardiographer who's collecting the data, because they will not have the ability to interpret the data for you. But I think when you sit with the cardiologist, and particularly if you're being investigated for hypertension, etc., where wall thickness really does matter in terms of picking out, early end organ damage, I think these are very valid questions and things that you should ask for. Also because, sometimes as clinicians, it is possible when we are uncertain to forward a data set to an expert group for additional analysis. And we tend to do that clinically as well. So when I have a patient in my NHS care who's got equivocal wall thicknesses and I'm not sure, I usually collaborate and work with the team at Bar to have a really sophisticated AI-based model that can give me very accurate sex and BSA stratified measurements, which can really unravel that conundrum. And then I can show the map, literally it is a bullseye map, and I can show the plot to the patient and say, look, most of your heart, even when we account for all those other factors, most of the heart measures a normal wall thickness, but you've got this really prominent spot here, which is really out of range. And therefore, I genuinely think that probably you do have hypertrophic cardiomyopathy. And I think we're all sort of slowly transitioning to that method. But I agree that I don't think this information has trickled down to the public, and they will not be in a position to advocate in most cases for that second opinion or for those more advanced analytical tools.
Yeah. No, thank you for that.
Can I ask a question about HRT?
Yes.
So I've just been at the I can never say this, gynecological endocrinologist. It's a really weird, conference, and there was a session on heart health I went to. There is a lot of discussion about the data from will HRT reduce your risk of heart disease or not. So it's controversial. People are not agreeing. People are not agreeing a lot about HRT and lots of other chronic diseases as well. But I just wondered what you thought about HRT and heart health.
So yeah, I think the research has been very confounded and very conflicted. So I don't think I can give you a very clear answer. I know that very often nowadays we are taking decisions as cardiologists, we're giving advice on an individual basis. And it's really about risk benefit.
Yeah.
Okay. And I think that's really important. I think we're all aware that there are risks of HRT use in women, and that this sort of blanket approach of giving HRT to all women of menopausal age is just not right. We know that that carries consequences. And I think there is a consensus about that. But we do appreciate that there are certain niche clinical situations where HRT can be of genuine benefit. And also those women might be at very low risk. And therefore there is a concept that perhaps if you are going to be considered for HRT, then why not speak to your GP and get your Q risk score measured, try and get an estimate of your cardiovascular risk, which based on your lifestyle and your family history will tell you what is your likely risk of coronary disease. And if your risk is moderate or high, then perhaps it might be worth you doing some preliminary tests before embarking on a longer journey of HRT therapy. So I think sensible advice is what I would recommend.
I totally agree, but there's some people in the cardiac field who say, no, HRT is going to prevent heart disease, and that really worries me. And the Q test you're talking about, so if you go to your GP, and I believe you have your blood pressure done and your cholesterol done and other markers, then they look at that all together. They don't just look at cholesterol. I know
Correct.
that, again, some people think they do that, but they do, there's a whole range of information that they look at together. So you might have the same cholesterol as another woman, but one of them might be given statins and one might not be, because it's more complex than that, isn't it?
Correct. And it's still not perfect. So in spite of these cardiovascular tools, as I mentioned in my talk, they still don't capture some really important sex-specific risk enhancers. And that is something to be borne in mind. So if you are one of those women who's had preeclampsia, who's had gestational diabetes, or you suffer from autoimmune disease, you suffer from SLE or rheumatoid arthritis, these Q risk scores are likely to underestimate your risk anyway. So again, have that conversation, advocate for your own care.
Do we have another question here? And have we got some questions online?
Yes.
Okay, right, we'll yeah.
Thank you, Gaby. Great presentation, eye-opening. The question is there a hope for us?
Yes.
So,
We need some hope.
so within the NHS and through your clinical career, can you see a change? Because most of us go under the NHS care. Has through all these years that you've been working at NHS, is there a change how women are treated, and is there any improvement?
Yes,
Good.
yes. So,
Maybe stop there. No, go.
as you know, a lot of doctors nowadays are women, so we're helping each other, okay? So there's this growing army of people who are completely cognizant about these problems. Minoka, and probably Takotsubo didn't even exist when I was in medical school, but now they do. So I'm better armed now at helping women than I was when I initially graduated, so that's improving. Funders and public health and policymakers are acknowledging the problem and its magnitude. Just for example, last week, the Wellcome Trust has set aside £55 million to fund a study called Visible, which is open worldwide for all people to investigate these phenomena, Inoka. Okay, so I'm sure that this, on top of the existing research that has already and is already being undertaken, which is of great quality, these data will change practice, will change care. And I think there definitely is hope for the future for women to really receive the level of care that they deserve.
I think a lot of the questions have got answered, and there's some great links online which we can share by email. So and lots of thanks from people, but can we just highlight this one? As a physically active perimenopausal patient who has recently experienced mild chest discomfort and underwent an ECG, that was me actually, but anyway, it wasn't me that wrote this. Can I be assured that this result is truly reassuring? What is the best way for patients in my position to advocate for themselves? Sorry, it keeps moving. Advocate for themselves. Why is it doing that? I think this mouse has gone a bit mad. Advocate for themselves, both in understanding the limitations of a single ECG and in asking appropriate follow-up questions when symptoms persist.
So I think this contributor is perfectly right. Just because you have a normal resting ECG doesn't exclude anything. You can still have any of those conditions I've discussed before, and probably many more. So the resting ECG is a very vague, simple surrogate telling you what the heart is doing at that moment in time under those resting conditions. It tells you nothing about the state of your epicardial coronaries. It tells you nothing about how your heart is going to perform under a situation of stress. So if any person, be it a male, be it a female, if you are of a certain age and you are developing chest pain, which is of recent onset, whether you have past risk factors or not, you should look into it. And there are now in most trusts around the nation now, there are rapid access chest pain clinics. And your GP, at the click of a button or pressing an email, will refer you to these rapid access chest pain clinics, where you will get reviewed rapidly, because that is the NHS priority. You will receive a rapid review. They'll take a history, and depending on that history, they will trigger a set of fairly urgent tests. This is assuming that your chest pain is stable. If you feel symptoms which are deteriorating, it's getting worse over time, and you feel, things are getting to a head, the advice is always to go straight to A&E, where you can have emergency and acute care. But to this contributor, I would say having a normal resting ECG is good news, but is not all the news, and additional tests should be undertaken.
So when I went, it was the receptionist who seems to triage you, doesn't they? And with no experience at all. Anyway, she just kept telling me to go to A&E, go to A&E and sit there for 20 hours and probably get something else while I'm sitting there. And in the end, they did go away, but they were mild, and I just thought, now knowing that information about the rapid clinic, I think that's really, really useful. And just to say, I am going to ask you, she doesn't accept you. I'm going to ask, I have a podcast called Why Didn't Anyone Tell Me This? And I've been doing some on chronic health conditions. I did a few last year, and I was looking for someone to talk about heart. So later in the year, I'm going to ask you probably, hopefully you will agree to come on and we can discuss all of this in much more detail. We'd have a podcast too, but there is a recording of this as well, so that we can delve into these all in a bit more detail. Are there any other questions? There was a
quick question. You referred to low, moderate, and high risk. What are the percentages of those? How are those measured? How does one know where you fall?
So, if, for example, you're using one of the online risk calculators, those are quite easy to use. Some of them use a more enhanced data set, but others are a bit more basic, and they will ask for things like your age, of course, your sex, your blood pressure. They will want to know your cholesterol levels and a few other things. And if you've got those data, because you've been to your GP and you've had some recent blood tests, you can, if it's not been done for you by your GP, you can go online and enter those data in one of these freely available online calculators, and that will output a percentage, and that percentage is your estimate of having a major adverse coronary event, in other words, a heart attack within, let's say, a 10-year window. And if you are in the low risk bracket, typically we would recommend that the statin is not needed at that point, unless there are other compelling reasons why you should take a statin. But if you're in a moderate or a high risk category, then definitely you should be on primary prevention. So these are calculators that are available online. I mean, ideally, you would get a health professional to compute it for you, just to make sure you're entering the right data and you don't get alarmed if you accidentally put in the wrong numbers or something like that. But they are available.
Can you send us the link to one, and we'll email everybody afterwards? Because I did one on osteoporosis last year, and there's an osteoporosis risk checker as well, which is really good. In 5 minutes, it will flag up if you should go and see your GP, because preventative medicine is obviously the most important. So if we can have one that you like, can I finish on a really positive note about how I'm all about self-care and preventative medicine. What advice would you give women to really look after our hearts?
So I think empowering you with the tools to look into your own health and well-being. I think exercise is very important, and doing that very regularly and consistently throughout life, very important. There are all the usual bits of advice. So don't smoke, drink alcohol just in moderation, eat healthy, cut down on your sugars or on all the fizzy drinks, try and, moderate the intake of carbohydrates and all those other things. Stress, manage it, sleep well. I think those are the key elements for cardiovascular longevity. If we are aiming for, healthy hearts at the age of 100, we need to be doing all of those things every day and religiously, but especially, I think, personally, the exercise.
So this is for everything, though. It's not just heart health, it's for every health. And I hate to plug my book, but I've got my book coming out 20th of March. Next Friday, we've got the book launch. And that's the whole book. That's everything that the book says. Reduce stress, exercise, eat well, everything you've just said is that that's basically the whole what my whole of my book's about, because it's a book about being healthy and happy over 50. And if we don't do this, I think that's a brilliant message to end on. It's not just heart health, it's reducing cancer risk, dementia, osteoporosis, everything. And we either make the decision to, and women keep telling me they don't have the time. Okay, so it's our decision. It's our decision, but we're hearing it everywhere I go. I'm hearing exactly the same thing. And in the gynecological endocrinologist, they said exactly the same about heart health. And there's a big session I went to about sleep. And it's that we've got to do all those things in our crazy lives that we live. We've got to do it. So I think we'll end there. I think we're just over 1 o'clock. Thank you so much. It's been a brilliant session. And thank you online. And we'll send there's some really good links in the chat, Sarah. We'll try and grab them.
There's a lot of people online. There are sort of 40 people online. And can I send you these questions? Of course. Address them separately, and then we can let these people know. Of course.
Do I have access to
We'll do it. We'll do it. Yeah.
Yeah.
Those. Thank you all online. I think we answered most of them. There's just a couple of very specific ones at the end. Yeah, there's a very specific one at the end. So thank you all very much. That was honestly, that was really, really good. Thank you.
Delighted.
It's still a UCL one, but I'm recording it online. But I'll Sarah's got your slides, has she?